It's a scary thought. Your 2-year-old suffers sudden cardiac arrest. You start CPR, get him to the hospital, and then his life is saved again by an innovative first-of-its-kind procedure.
The device has saved his life at least twice, so he's doing incredibly well. The point of having a device is not to let the child keep getting shocked, but it's really a safety net. And so we've been adjusting his medications, but really what the device has allowed us to do is to do that safely.
That's Dr. Sunita Ferns, the Director of Pediatric and Adult Congenital Electrophysiology at OSF Children's Hospital of Illinois. And I'm Shelley Dankoff, your host for OSF HealthCare Accelerated. We appreciate you tuning in and remind you to be sure to subscribe, rate, and review wherever you get your podcast. Being innovative sometimes means being willing to do something different, perhaps using a device in a way it hasn't been used before. That's exactly what a team at OSF HealthCare Children's Hospital of Illinois in Peoria did to save a young child's life. Joining us to talk about this remarkable achievement are Dr. Mark Plunkett, Chief of Pediatric and Congenital Heart Surgery, and Dr. Sunita Ferns, the Director of Pediatric and Adult Congenital Electrophysiology at OSF Children's Hospital of Illinois. Thank you both for being with us. I've been looking forward to this conversation because the teams at Children's Hospital do such great things. So it's great when we can talk about really cool stuff. But this particular case actually started with some quick-thinking parents, didn't it?
It most certainly did. And when the mom realized that her child was having a cardiac arrest, she jumped in, started CPR, and really that's what saved this little boy's life.
Yeah, the fact to recognize, first of all, a 2-year-old who was otherwise just running around and then all of a sudden isn't. It stresses the importance of knowing child CPR, right?
That's correct, yes. And they were quick thinking and quick acting, and were able to maintain that resuscitation until the child could be transported to our center where we were able to revive him.
So the ambulance brings him in, arrives at Children's Hospital in the emergency room. What happens from that point?
So from that point, the ER physicians took over. They realized that this child had suffered a resuscitated cardiac arrest prior to the ambulance bringing him in. They actually had to give him 5 shocks in the field, and he got a very heavy-duty medication that helped revive him. And so by the time he came in, we went into full protection mode. You have to think about protecting the brain. The ICU team was down in the ER very soon. Cardiology, cardiac surgery, all the important team players were involved.
We're going to pause there on this case because that also brings up OSF Children's Hospital of Illinois has all those players in place. You're in Peoria, Illinois. You have over 140 subspecialists. That's important when it comes to this kind of life-saving work, isn't it?
Yes, it is. It's important to have a comprehensive team of, providers and have them available on the spur of the moment, if you will, as in this situation.
Yeah, and a team that works well together, too. You kind of know what everybody's going to do, and you just, like you said, hit the ground running. Everybody knew their role and figured it out. So this child was diagnosed with Brugada syndrome. What is that?
So Brugada syndrome is a very rare channelopathy. It's due to a mutation in a sodium channel. And our heart, like our brain, has ion channels. And when there's a certain channel that loses function, that causes malignant arrhythmias. And that's really the pathogenesis. It's a genetic mutation. And so in this particular child, he was the first one in his family who had it.
Interesting. So if this didn't happen, they never would have known. He potentially could have gone through life, or was it going to show up at some point?
And, at this age, the particular presentation of Brugada can be very malignant, and oftentimes children don't survive an arrest. And so if you think about sudden infant death syndrome, crib deaths, about 30% of them could be attributable to channelopathies like this. This little boy was very fortunate that his parents knew what to do and jumped in immediately and saved his life.
I have to ask the question, though. I've had little children. I understand this. If it was me, I would have been freaking out. Obviously, they're the ones who saved his life with the CPR. But at some point, the questions have to be running through their head. How does my presumably healthy child find themselves in this situation? What were the parents going through?
I can only imagine that it was a very traumatic experience for them. It took, after the immediate shock of realizing that their child had a life-threatening arrhythmia, they received more information from the team. And I think the most important thing here was the child's brain was preserved through all of this. And once they realized that their child was, back with them and a healthy, smiling 2-year-old, they were delighted. So I think it's a host of emotions that parents go through, but then really receiving the education and learning that you can have really a normal lifespan because this was detected and treated early, that their child could do everything else that you would expect a 2-year-old to do. I mean, if he wanted to join Little League, he could go ahead and do that. If he wants to go be a fireman or a physician, he can go ahead and do that.
Yeah, I think the fact that this child remained neurologically intact really points out the reaction time that these parents had in assessing and then intervening on the situation. It also, of course, points out the importance of knowing CPR and getting trained to use it, trained in such a way that it just comes almost automatic in the scenario when you need it.
Let's turn to the device itself, the EV-ICD. Now, in the past, this has only been used on older teens and adults. It had never been used on a child this young. What is the device? How does it work? What is it designed to do? Tell me about that.
So if you've seen these yellow or red boxes in the field, they're called defibrillators. They're
Right.
external defibrillators. And what an automatic defibrillator does is it provides a shock that jolts your heart back into a normal rhythm. And so what this little device does is it holds that power to be able to shock a child or an adult out of an abnormal rhythm to sync their heart back in rhythm again.
It sounds, and again, I'm going to turn to the surgeon here. So when it comes to putting this in, but how did you guys come up with the thought of this could work in this young child when this had never been used that way before?
Right, and this is called an EV-ICD, which is an extravascular implantable cardioverter-defibrillator, okay? And many of them are implantable, but they have to be placed in the vascular system. So as the patients get smaller and younger, that becomes very problematic. The great thing about this device is that it sits, you can put it in almost a minimally invasive approach. It sits below the breastbone or the sternum. It doesn't have to actually sit on the heart. You don't have to open the pericardium. And then the generator can be placed somewhere close by, usually in the upper abdomen in the older patients, but we had to put this one in the armpit, if you will, the axilla, because that was the best place to put this, the generator or the battery. It'll also allow him to grow without the need for replacing it anytime soon, as there won't be too much tension between the device inside and the generator.
So could this device stay in him for the rest of his life, or would there be need for a replacement, or will he outgrow it, that kind of thing?
Usually the generators or the batteries on these newer devices last at least 10 or 12 years, but depending on use, may have to be replaced down the line. But certainly a long period of time without having to replace it.
And by the next time he needs it, he would be much bigger too. So you have a different place.
Exactly, and we may next time go with a intravascular device as he gets older and bigger. Or they may have a newer version of this device at that point. The technology is advancing so quickly.
How did it cross your mind to even use it? Again, it had never been used in a child like this, but you knew what the device was designed to do. Did you because what would have been a typical treatment otherwise for Brugada?
The child would have needed an ICD, but prior to this device being available and us having decided to at least trial it, what we would have done was we would have involved a cardiac surgeon, such as Dr. Plunkett. He would have had to perform open the child's chest, open up the child's pericardium, which is a sac that surrounds the heart, and tack some, pretty hefty leads on the child's heart. And then the device would actually sit in the abdomen. So the device would go across two body cavities. And so when the child grows, there's tension on that wire that Dr. Plunkett would have to tack down. So it's a very tedious procedure to put a device, an implantable defibrillator in a child this young. So how did we think it could work? It was just it was an idea. I wanted to know if the lead would actually fit the child. So I taped it onto his chest and I got an x-ray done and it just about fit him. And I said, it looks like it'll fit and we can keep it hidden behind the breastbone. So let's try it. We, of course, had a backup, traditional system in the operating room. And that was available. And we always trial these devices. So once we put them in, we put the child knowingly into a life-threatening rhythm. We let the device shock him to make sure that he can get out of it, because really we want to make sure it works before we let him go.
Yeah, and I have to give Dr. Ferns credit for calling this to our attention, but I immediately jumped at it as a great idea, knowing what we would have to do otherwise to implant the older devices, which, as she said, would require major operation, opening the chest either through a sternotomy or thoracotomy, accessing the heart, putting in either coils or patches and that sort of thing. And those devices are not as effective. Those are older technology. This device is much more effective and can be placed with a much more minimal operation.
Yeah, the other way is full-blown open heart surgery, right? And that opens you to even other things like infections and stuff. Just anytime you're doing more extensive stuff, there's other things that can happen.
Exactly. And if I'm correct, this baby went home like in a day or two after the operation. So that says a lot right there as far as the difference versus staying days to weeks after a more major procedure.
Okay, so what was that conversation like with the parents? Because you're like, okay, we've never done this before, but they obviously understood the advantages of it. But still, you're talking about a 2-year-old, you're the parents, it had to be scary to think, all right, we're going to do this. We have confidence. Was that kind of how it went?
I think so, and I think it's really building trust with the family and they trusted our team to do what was right for their child, and it worked.
Okay, Dr. Plunkett, you've called this history-making procedure a game changer. Why?
Because with this one patient showing that this device could be implanted safely and effectively, we have taken a device that was designed for adults and adult-sized patients and suddenly opened it up to the pediatric population all the way down to a 2-year-old. And that really just has expanded its application to the pediatric world, which it wasn't initially designed to do. Now, historically, if you look at a lot of the devices we use in the pediatric world, a lot of them were developed in that similar way, in that they were initially designed for adults, and then sometimes they're miniaturized or changed, but they can then be applied to the pediatric population. But of course, it takes that first case to prove effectiveness and safety.
So do you think Medtronic will kind of streamline the size of it for a smaller patient?
They may look at that so that we can go down to even a smaller child than our patient here, and that may be on their minds at this point.
Yeah, it's scary to think you need to put a defibrillator into a child, but it's nice to know that it exists. So you've published a paper on this, and so it's out there. Have we been contacted by others about the use of this, and are they going, okay, let's discuss this? Have you heard from others?
Sure, yes, and it was published in the Annals of Thoracic Surgery, and we made a very descriptive report so that others could read it and understand what we did. But yes, we've been contacted quite a bit, and many asking how our patients doing so that they can use the device in the same way.
And as such, like we spoke about before, it's just so incredibly rare for a child to survive a cardiac arrest like this in the field, and to have, to be neurologically intact. And we've had some other centers that have reached out because they've had a toddler or an infant who presents like this, and they've asked us what our experience has been, and asked for our input. So I think it has opened, it's opened the door to using this device for much younger kids.
Okay, so let me ask the question: how is the patient doing?
The device has saved his life at least twice, so he's doing incredibly well. He has a particular syndrome, and we need to. The point of having a device is not to let the child keep getting shocked, but it's really a safety net. And so our aim is to work on his medications such that we don't reach the situation where the child gets a shock. And so we've been adjusting his medications, but really what the devices allowed us to do is to do that safely.
Yeah, but like you described earlier, he can have a typical lifestyle. I mean, so he'd be able to go out and do everything every other kid does.
Yes, and it could be possibly in the future, as he gets older and bigger, if we have to change the generator out, we might move it from his armpit and put it somewhere a little,
less like you could bang into it as a kid.
Exactly.
Yeah.
Yes.
Okay.
A little bit out of the way for his activity and things.
Okay, that's so interesting. So I'm going to ask this question: what does this mean for the team to have been a part of this? Is this one of those, this is why I went into my specialty moments, or what does it mean to you to have been a part of this?
Yeah, it was a very special moment because we did something that was creative and innovative in implanting this device in this child. Again, I give Dr. Ferns credit for initiating it, but then it was remarkable how we brought all of our team together, got everybody on board, and then were able to successfully do it in a relatively short time frame, and have the child do well. So a great moment for our team.
And it's incredibly rewarding from many different standpoints. One, we've avoided an extensive surgery for this child. We've saved him a lot of pain and suffering that he might have experienced after a conventional device. Two, it sort of validated the trust the parents put in our team, and we were all ready to have a backup conventional system, but this worked, and it opened the door to using this device across the world. And when companies launch devices like this, there is just trials are done in adults, and it's cases like this that sort of open avenues for it to be used in different populations, and I think that's what this has done.
I have to ask: were you holding your breath in the OR when you intentionally put him into, stopped it, and you were waiting for this? I have to believe everybody went. Yeah, and just held your breath.
It was a moment of truth, believe me, because we're obviously going out on an edge a little bit to implant this in this child, and then of course we have to test it in the operating room. Obviously, we have safety nets in place if it doesn't work. But yes, that was the moment of truth when the device actually worked, and it worked the first time.
Was there a cheer?
It was
most certainly.
Almost an applaud.
Well, who wouldn't? I mean, seriously, who wouldn't? Because I'm sure there were people just on the periphery who may not have been directly involved in the surgery going, okay, we want to see how this, because people talk, they hear, and again, just the coolness and life-saving effect of it is the thing. I know how the teams just love being a part of that, and so having the opportunity to be there and see it.
Yes, and celebrate the success.
Yeah, and ultimately the little boy too, who we will continue to send
Absolutely.
positive thoughts to, and we'll look forward to, hopefully down the road, we'll see him playing ball or something, and it'll be, wait a minute, that was that child, so that's great.
Well, when you do something for the first time like this, then everybody is sort of tracking that and seeing, how the patient does and the success of it long term. So yes.
Absolutely. Okay, and I'll ask you real briefly, any other cool, innovative things on the horizon or do you just always look, the opportunities just present themselves whenever, and you never know what will walk in the door?
I think a lot of times in pediatric electrophysiology and pediatric cardiac surgery, we use off-label devices traditionally used for adults. What I can think of now is a leadless pacemaker system that's been adapted to pace babies, premature babies, and that's just a very innovative use of the leadless pacemaker. And I think that will, sort of change the world of pacing for very, very little babies.
Yeah. And as in this scenario, we're always looking at the adult world and those devices, trying to think, could we use them in babies or children, and would we have to miniaturize them, or how would we have to alter them in order to apply them? But that type of thing is happening all the time, and she's right. A lot of what we use for the operations on children are what we call off-label. In fact, they weren't proven in the pediatric population. They were initially designed for adults, and that can be anything from materials to valves to stents to, anything that we might need for repairing congenital heart defects.
Yeah, we've done a podcast on the dual leadless pacemaker, so people can check that out too and learn more about how those work in the adult population. But it's neat to hear that they're looking at using it in the pediatric patient because, sadly, but yet positively, having a team at Children's Hospital allows you to have access to those things, and you have all those specialists who can come in and put the great minds together and be like, let's try this. So Dr. Mark Plunkett, Dr. Sunita Ferns, thank you so much.
Thank you.
And thank you for the great work. And thank you for joining us as well. And remember, you can listen to all of our podcasts at osfhealthcare.org/accelerated.